السلام عليكم جميعا. نعتذر عن التأخير، كان في تكنيكال بروبلم وحالا هنبدأ. دكتور نبيل اتفضل حضرتك كمل، آسفين جدا.
ايوه، ولا يهمك يا بيه.
دكتور نبيل، السلام عليكم. اسفين
كده
التكنيكال
تمام بقى واضح؟ وعليكم
كونكشن
السلام ورحمة
ايرور.
الله. ولا يهمك يا باشا.
اتفضل.
تمام، واضحة الشاشة؟ واضح الشاشة خلاص والصوت وكله تمام؟
كله تمام، اتفضل كمل.
تمام، اوكي. يبقى زي ما قلنا الانتراسيربرال inside the brain tissue itself. Number 1 and number 2 are usually due to birth trauma. Number 3 and number 4 of the fetus usually premature and exposed to hypoxia. الكلينيكال بيكتشر بيكون فيه altered consciousness or يعني it is vary from complete coma or just lazy baby or he is not alert. Flaccidity, breathing is absent, irregular and periodic or gasping. The eye, no movement or pupil may be fixed and dilated if it is severe. Obstructive rigidity, twitches and convulsions if the anoxia is severe. Vomiting, high-pitched cry, anterior fontanelle is tense and bulging. Lumbar puncture reveals bloody CSF. Investigations. Ultrasound is the primary facility that can diagnose intracranial bleeding, but CT will be confirmative. Inspired CT is not good for this age or for the newborn, so we prefer to do an MRI. But we will depend on the cranial ultrasound if we have experts on ultrasound. Prophylaxis, vitamin K 10 mg IM to the mother can be given late pregnancy or early in labor. Generous episiotomy can be done, especially in premature. Sometimes they are saying the baby is very small and they will pass. Yes, it does, but sudden compression and decompression will cause bleeding in preterm babies and in breech delivery. First delivery is carried out by an experienced obstetrician, respecting the instruction for its use, and it is rare now to use the forceps. Treatment will be supportive treatment. Intracranial hemorrhage may result from birth trauma or asphyxia and rarely from a primary hemorrhagic disturbance or congenital vascular anomaly. Intracranial hemorrhage often involve the ventricles. Intraventricular hemorrhage, or IVH, we have, as we told, 4 grades. Grade 1, if it is just in outside, and we are naming it German matrix bleeding. Grade 2, if it is inside the ventricle and the ventricle is not dilated. Grade 3, it is if inside the ventricle and dilated, the ventricle started to dilate. And grade 4, if the ventricle is full of blood and will go to the brain tissue also, or brain matter. Intracranial hemorrhage in preterm will happen in the first day. We will take this instance. 60 to 70% of the babies who weigh 500 to 750 grams, 10 to 20% of 1,000 to 1,500 grams. IVH is rarely present at birth. However, 80 إلى 90% of these cases occur between the 30 days. So the first cranial ultrasound should be after 3 days. So to say this baby is normal, because if you will do in the first day, you may find normal, but it will happen in second or third day. 50% occur in the first day. 20 to 40% of cases progress during the first week of life. Delayed hemorrhage may occur in 10 to 15% of patients after the first week of life. Clinical manifestations, the most common symptoms are diminished or absent motor reflex, poor muscle tone, lethargy, apnea, somnolence. periods of apnea, pallor, or cyanosis, failure to suck well, abnormal eye signs, a high-pitched cry, muscular twitches, convulsions, decreased muscle tone, or paralysis, metabolic acidosis, shock, and a decreased hematocrit or its failure to increase after transfusion may be one of the indications of continuous bleeding. The fontanelle may be tense or bulging. Diagnosis: intracranial hemorrhage is diagnosed by transcranial ultrasound, and if we can not diagnose and want to confirm, we will do a computerized tomography or CT, but CT has a high dose of radiation. That's why we prefer to do an MRI. I will go to the peripheral nerve injury. The most famous are the brachial plexus. It is due to overtraction on the neck, as in shoulder dystocia after coming head in breech delivery. This is the mechanism how it will happen. El brachial plexus, Erb's palsy, it is the most common due to energy to C5 and C6 roots. The upper limb drops beside the trunk, internally rotated with flexion. This we are naming it policeman step position or waiter step position. اللي هو العسكري اللي واقف انتباه. بعد كده الكلامبكس palsy, it is less common due to injury of C7, C8 and first thoracic root. It leads to paralysis of the muscles of the hands and weakness of the wrist and fingers flexor. Treatment will be supportive to prevent stretching of the paralyzed muscle, physiotherapy, massage, exercise, and thoracic stimulation. Recently, there is a microscopic, very delicate operation, microscopic nerve grafting can help, and we have one in our hospital was done. This again, how the brachial plexus injury, as you see, there is complete avulsion or partial tear, and it will depend on the symptoms will depend on, and the prognosis also will depend on whether the injury was complete avulsion or complete tear or just a contusion. C4 will be phrenic nerve palsy, C5, C6, and C7 Erb's palsy, and Erb's Duchenne palsy 80% of brachial plexus injury. C8 thoracic 1 clumps palsy, C5 to thoracic 1 complete brachial plexus injury or Erb clumpic palsy. Here is the picture how the upper limb will be, as we told, like the policeman position. Injury to the brachial plexus may cause paralysis of the upper arm with or without paralysis of the forearm and hand, or more commonly paralysis the interior arm. Approximately 45% are associated with shoulder dystocia. These injuries occur in macrosomic infants. That's why if you will see that the baby is big, it's better or prefer to start CS from the start. And when lateral traction is exerted on the head and neck during the delivery of the shoulder inverted presentation, and when the arms are extended over the head in breech presentation, or when excessive traction is placed on the shoulders. In Erb's palsy, Erb's Duchenne, the injury is limited to the 5th and 6th cranial nerves. The characteristic position consists of adduction and internal rotation, and the arm pronation of the forearm. More of a flex is absent or affected on this side. This is one of the babies who suffered this injury. There may be some sensory impairment on the outer aspect of the arm. The power of the forearm and the hand grasp are preserved unless the lower part of the plexus is also injured. The presence of the hand grasp is a favorable prognostic sign. Lambic, severe from the brachial palsy, injury to the 7th and 8th cervical nerves and the first thoracic nerve produces a paralyzed hand. Horner syndrome is also one of the injuries. If the sympathetic fibers of the first thoracic root are also injured, it will give us paralyzed hand and ipsilateral ptosis and meiosis. This is the picture for us. Prognosis depends on whether the nerve was merely injured or was lacerated. If the paralysis was due to edema and hemorrhage about the nerve fibers, function should return within few months. If due to laceration, permanent damage may result and may need grafting. Treatment, as we told, if the paralysis persists without improvement after 3 to 6 months with physiotherapy and everything, so neuroplasty, neurolysis, end-to-end anastomosis, or nerve grafting offers a hope partial recovery. Phrenic nerve injury will affect if there is affection to the 3rd and 4th and 5th cervical nerves with diaphragmatic paralysis must be considered when cyanosis and irregular and respiration develop. Such injuries usually are unilateral, are associated with ipsilateral upper brachial palsy. This is a picture. You will raise the copula of the diaphragm on the affected side. The diagnosis is established by ultrasonography or fluoroscopic examination which reveal elevation of the diaphragm on the paralyzed side. There is no specific treatment. Infants should be placed on the involved side and given oxygen if necessary. Recovery usually occurs spontaneously by 1 to 3 months. Rarely surgical plication of the diaphragm may be indicated. Fracture clavicle. The clavicle, this bone is the most fractured during delivery, more frequently than any other bone. It is partially vulnerable when there is a difficulty in delivery of the shoulder in vertex presentation and if extended arms in bridge delivery. Here is a picture of fractured clavicle. The infant characteristically cannot move the arm freely on the affected side. Crepitus can be, but it is not preferred to do it as it may injure vessels under the clavicle. But we are just saying that you can have this sensation. Then we have discoloration is occasionally visible over the fracture side. Treatment consists of immobilization of the arm and shoulder on the affected side. A remarkable degree of the callus develops at the site within a few weeks and may be the first evidence to the fracture if it is unnoticed. The prognosis is excellent. Other rare injuries like liver, spleen, rupture viscera, laceration or rupture, fracture of the humerus, and femur bones with facial nerve injury. Here you can see like this hematoma in the liver and rupture liver or spleen, maybe during sudden compression on the abdomen. Here fracture humerus, many pictures. This is a facial nerve palsy. You will find the baby cannot close his eye on the affected side, and if he will cry or laugh, the mouth will be deviated to the affected side. Thank you very much, and I hope that it was helpful and was not so long. Thank you.
Thank you very much, Dr. Nabil, for this comprehensive lecture. And any questions? Just to ask you, Dr. Nabil, about the prevention. It is a task of obstetrician, prevention of this birth trauma.
Yes, you are the proof of the Gyne. So just we will go as per the indication. If there is a real indication for forceps or for ventouse, or we can from the start judge and go to cesarean. Many are doing now cesarean, but as I just mentioned, it can happen with liver obstetrician and with junior or anything. But we have to just to take the correct decision for each case to give her a chance. If she can pass normally, safely, okay. But a fetal macrosomia, for example, 5 kg or 4 kg and 4 kg and fallopian disproportion, and we are giving her a chance to deliver normal until the head will be backed and the baby will be cyanosed and will start laceration, deceleration, then we'll go to CS. So just we are saying go with the indications and go with your guidelines and try to do your best. And you cannot predict what will happen, but anyhow, if there is something avoidable, we have to avoid it.
Thank you very much. Thank you, and see you inshallah next meeting. Thank you.
Thank you. Thank you. Bye
bye. ممكن stop sharing.
Yes, yes, I will.
Now we start the third lecture, and the fourth speaker, Dr. Bassam Al-Qaddoumi, the eminent, famous OB-GYN consultant, Saudi German Riyadh, will give talk about gestational diabetes. تفضل دكتور بسام.
Thank you very much. Should I start? Good afternoon, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks very much for Dr. Lutfi and the Mr. Tamer and the IT team and the SGH Riyadh for this successful meeting. I'll be talking today about the gestational diabetes, which is diabetes in pregnant women. Among the things I will discuss is the definition, the etiology, and the possible causes of the disease, the incidence of the disease, and the management, how to manage the disease. And by the end of this session, we'll be able to notice all that. Starting with the definition of the gestational diabetes, it is high blood glucose that develops during pregnancy and usually resolve after delivery. So it's a transient during pregnancy. Just starts and usually starts in the second or third trimester of the pregnancy. Blood glucose level normally is 95 milligram per deciliter or less fasting. And 1 hour after the meal, it will be 140 milligram per deciliters. Other increase above this will be considered to be studied and decide whether this is diabetes or not. The etiology of gestational diabetes is really not known. But we know something about the causes, such as placental hormones produced by the hormones and the placenta and the baby block the action of the mother's insulin, causing insulin resistance. So insulin will be resistant to work, so blood sugar will be increasing in the pregnant lady. And in pregnancy, the lady will gain more weight, and sometimes it's enormous. So her insulin production will not be enough to reduce her blood sugar, and she will develop gestational diabetes. There are a lot of risk factors that, if they are present, they will cause gestational diabetes. Obesity. Well, BMI more than 30, body mass index more than 30 will be a predisposing factor, and strong predisposing factor. Lady being inactive, not doing any exercises, not walking, not active in her house or in the work, this will be another cause of gestational diabetes. If she have had gestational diabetes in previous pregnancies, that's another cause. If there is a family history as well, and if she have had a previous delivery of a large baby more than 4 kg. The incidence is 2 to 10% of pregnant ladies will develop GDM. This is among the American society. In the Middle East, it's a bit more. It's going up to 12% of the pregnant ladies. 50% of the GDM women will develop and being considered as type 2 diabetes, which is a high incidence rate, actually. What symptoms do we have in gestational diabetes? Actually, it may be silent. There is no symptoms at all. And that's why the antenatal care is very essential and important for every pregnant woman, so that we can discover any abnormality, especially gestational diabetes. But some of the symptoms, she may have mild dryness of the mouth, and she may feel thirstier every now and then, and she can go and pee too many times during the day. Getting GDM for the pregnant lady will have an effect on the baby and the mother. The mother will have an enormous increase in the weight, and she will have an increased risk of high blood pressure and preeclampsia, and even sometimes eclampsia, eclamptic toxemia. And there will be an increase in the C-section rates. Infection will be much more for them, especially if we are doing cesarean section or episiotomies, large episiotomies. And she is a candidate to be a future diabetic after she delivers. The effects on the baby will be macrosomia, that's 4 kg and more. This will impose and cause difficult delivery, and it will predispose for increased birth injuries. Birth injuries has been done by Dr. Nabil, and he went through them very successfully just half an hour ago. Premature deliveries, which will impose on the baby by RDS, respiratory distress syndrome, and other breathing problems, low blood sugar, hypoglycemia, which is sometimes maybe fatal, or it's a big cause to be admitted to the NIC. Obesity and may develop type 2 diabetes later in life for the baby. Baby may die during pregnancy, and he may die during delivery or even after delivery because of, as you can see in the photo, how much big can be the diabetic baby could be. We have delivered here just 1 month ago about a 6 kilogram baby. Actually, it was 5.7 kg, and it was successfully delivered normally. That was a good luck. How to treat gestational diabetes? It has too many steps and factors to be done for the pregnant lady. She has to have a good lifestyle, healthy diet, and low fats and calories, reduce sweets and chocolates. And everybody likes them. So, well, sometimes that will not be successful. She should eat fruits and vegetables and whole grain and lean proteins. That's the main thing we advise for a lady with GDM in her pregnancy as a first step to conquer gestational diabetes. Second thing is to advise her to stay active with regular physical activities, lower blood glucose, and relieve discomfort. This will relieve her discomfort or back pain or swellings or constipations, and it will improve for her her sleep. She can sleep well during the night. If she can do 30 minutes of moderate exercise, walking or swimming, that will help too much. Blood sugar monitoring during the treatment should be done 3 to 4 times per day so that we are sure we are controlling the blood sugar of the lady. If the diet and exercise are not enough, which usually do not succeed, we have to go to use the medications. A small number of women with GDM will need insulin injections. But we have done it, and we have needed for some women. Oral medications, there are still more researches to be done and to confirm their safety and efficacy. So we don't rely on them so much. The big question for the gestational diabetic women is when to deliver and how to deliver. When to deliver, if the blood sugar is controlled, well, delivery is at term. We can wait till we reach the term, which is 40 weeks, and sometimes 40 weeks plus 1 or 2 days. How we deliver? Usually, if everything is within control, normal, we go to normal delivery. Otherwise, we do C-section. C-section is highly recommended in gestational diabetes, especially if the baby is macrosomic, and we have to avoid birth injuries or the trauma to the baby. And thank you very much.
Thank you, Dr. Bassam, for this interesting lectures. And you ask any questions? Okay. Thank you, Dr. Bassam, for this comprehensive lecture. What about the screening for gestational diabetes?
Well, screening usually, and the gestational diabetes is, as we said, usually starts in the 2nd and 3rd trimester. The best thing to do is the glucose tolerance test at the 24 up to 28 weeks of pregnancy. But during any visit, during the antenatal care visits to the OPD clinic, we can just check the fasting blood sugar and see whether it is more than 95, as we said, or or not. This will give us a hint. Returning back, it is the most important and reliable test is at 24 up to 28 weeks of pregnancy.
Thank you. Thank you,
Thank
Doctor. Thank you, Dr. Mehta. And مين السبيكر والفيديو؟ السبيكر. Start. The lecture now will be about uterine fibroid disease. The uterine fibroid are benign uterine tumor of smooth muscles The fibroid frequently causes abnormal uterine bleeding, pelvic pain, and pelvic pressure, urinary symptoms, bowel symptoms, and pregnancy communication. So each tumor or each myoma arises from one smooth muscle cells of the myometry. It affects about 5 to 10% of all women globally. But uterine fibroid is the #1 cause of hysterectomies, surgical removal of the uterus across the world. Of course, the incidence increase in Africa and in Black peoples. Hysterectomy, the second most common surgical procedure in women, is easily avoidable in most cases. India, about more than 2 million hysterectomies per year, which is due to uterine myoma. Uterine fibroids are benign growths of the uterus that often appear during childbearing years, also called leiomyoma, or myoma, or leiomyofibroma, according to the histological structures containing smooth muscle fibrous tissue like this. Uterine fibroids are not associated with increase in size of uterine cancer and almost never develop into cancer. Only the percentage is 0.5% can change into uterine sarcoma. Your doctor may discover fibroids incidentally during pelvic examination or perinatal ultrasound. Uterine myoma are most common pelvic tumor, which is about 70% of women at age of 45. The classification of fibroid according to the location in the uterus may be subserosal, يعني under the outer surface of the uterus, intramural, in the wall of the uterus, in the myometrium, intramyometrium, or submucosal under the lining of the myometrium, or pedunculated, growing with stalk outside the uterus. Most of fibroids in the uterus are subserosal, intramural, or submucous. This is the subserosal without pedicle, and this is the intramural. This subserosal also without pedicle. This is submucosal. When it come out, stalk or pedicle, become it pedunculated or broad ligamental, can be broad ligamental also with pedicle. What are the symptoms of the disease? Many women who have fibroid don't have any symptoms. And those that do, symptoms can be influenced by the location, the size, and number of the fibroid. In women who have symptoms, the most common sign and symptoms of uterine fibroid include menstrual bleeding, menstrual periods lasting more than a week, menorrhagia, pelvic pressure pain, frequency of urination due to pressure on the urinary bladder, difficulty emptying the bladder. It may lead to retention, back ache and leg pain, and huge tumor affecting the nerve plexus or the pelvis. Bladder compression and intestinal symptoms. Constipation can result from intestinal compression. The cause of bleeding, fibroid can cause abnormal uterine bleeding like menorrhagia, metrorrhagia, submucosal bleeding can be severe enough to cause anemia. How to diagnose? Number one, pelvic examination are frequently found incidentally during routine pelvic exam, and there is irregularity, nodularity of the uterine examination, suggesting pressure of the fibroid. Ultrasound. The ultrasound is confirmation and picture of the uterus confirm diagnosis and to map major site location and the vascularity. Laboratory test, we have to do CBC and renal function test to see the effect on the kidney and pressure on the ureter. Hysteroscopy, can be used to detect any uterine myoma, submucosal or polyp, and also we can use what we call sonohysterography to see the intrauterine pathology. For the patient, when she can go to the doctor, she must, if there is pelvic pain, heavy prolonged bleeding, spotting, difficulty emptying the bladder, or unexplained anemia. Risk factors for uterine fibroid are most common pelvic tumor, with about 70% of women by the age of 45. However, many fibroids are small and asymptomatic. About 25% who fight 50% of Black women eventually develop symptomatic fibroids. There are few known risk factors for uterine myoma other than being women of reproductive age. Factors that can have an impact on fibroid development include race. Though all women of reproductive age could develop fibroids, Black women are more likely to have fibroids than are women of other racial groups. In addition, Black women who have fibroids are at younger age, and they are also likely to have more large fibroid along with more severe symptoms. Hereditary, if your mother or sister had fibroids, you are at increased risk of developing fibroid. Other factors starting your period at an early age, obesity, vitamin D deficiency, having diet which have high meat content and lower green vegetables, fruits, dairy, and drinking alcohol, including beer, appear to increase the likelihood and risk of developing fibroids. Asymptomatic fibroids don't require treatment. Patients should reevaluate periodically. Symptomatic fibroids, medical options, suppression of ovarian hormone to stop bleeding are suboptimal and limited. However, clinicians should consider first trying medical treatment before doing surgery. Gonadotropin growth can be given before surgery to shrink the uterine myoma, but these drugs often stop menses and allow blood to increase and correct any anemia. In perimenopausal women, expected management can usually be tried before symptoms may resolve as fibroid decreases size after menopause. We will stop till now for uterine myoma, and we'll consider it later about the treatment. We will introduce our eminent and famous doctor in Saudi General Hospital, Dr. Atif Bassas. He's a pediatric consultant and an eminent general surgeon in our hospital. Dr. Atif Bassas will give us a talk about bariatric surgery on gynecological problem. Atif, تفضل.
And how we move. Okay. Assalamu alaikum. Thank you very much. I'd like to present you my talk about the obesity in female population, pros and cons. Now, this issue with obesity has been actually a major part of my life, sort of service in the surgical field. I'd like to start by introducing what is obesity, and the most concise and nice description I found was a person who has an excess of body fat that could impair health. It increases, the obesity increase the risk for various diseases, disabilities, and it can be even a reason for an early death. We'll talk about this in the next slides and elaborate on more of the other reasons for or complications. Another description is obesity and overweight are increasing. Sorry, this is a prevalence of the disease in Saudi Arabia, and as you could see, there is an overall obesity prevalence of 35.5%. This is actually a big number because we are considered at the moment in the top 10 countries in the world suffering from obesity. We are in the same sort of line with countries that are well known for this, like the United States. The only countries that run in front of us is the Samoa in one of these islands in the North Sea, or and that is actually a tradition of keeping those people themselves fat. Other than that, Saudi Arabia and Kuwait and the Gulf countries are standing on the top of those obese known countries. As you could see from the obesity in the female, it is up to 44%, and the obesity in male is 26.4%. Now, what are the causes of obesity? Of course, there's numerous numbers of causes, and it goes from the high calorie food intake, which is coming sort of very much in the last, like say, 20, 30 years, where a lot of this fast food is becoming a major part or chunk of our daily intake. The sedentary lifestyle, as you all know, with the use of cars and sort of depending on facilities, and of course that is partly due to the unfortunate weather that we have in this part of the world. The midlife weight gain, as you all know, that with increasing age, usually the metabolism will come down, and the possibility for increasing weight is much higher, and especially at the menopausal age. Other endocrine problems like hypothyroidism, Cushing syndromes, and polycystic diseases and syndromes have been linked to obesity. Now, hereditary is a very tricky issue, but we've seen that up to 80% of the children born by a fat father and mother are sort of in the mode of developing obesity as well, and we have seen this a lot in our practice. As a matter of fact, we've seen recently that those families, they come forward with their children asking for an early treatment, i.e. the surgical treatment that we provide from our side as surgeons. And the usage of drugs, as you all know, all these steroids that are, by the way, we call the steroid is the blind magic medication. So in most of those allergies and all these problems that we face, steroids is a big major issue to blame for the obesity. Oral contraceptive pills and anti-epileptics, antidepressants, and antihypertensives. Those are all drugs that have been blamed to increase the risk of developing obesity. Now, what are the complications? I have started at the beginning talking about the complications, but the number is an endless list. As you all know, we start by the coronary heart disease and heart failure, the high risk of developing strokes by all sort of its kinds. Diabetes mellitus is a very big issue that we consider especially in our part of the world, I mean the Gulf region. Just to give you an idea, we're talking about 30,000 patients developing renal failure in Saudi Arabia that needing dialysis. More than 80% of them are suffering from obesity, and this is a major health issue that is costing the country a lot of budgets and so on. Now, depression is a major problem after obesity, and one of the mode of depression that interests me actually, especially recently, is the depression that we could see in young boys at the age between the 11 and the 18, and this is really something that has been studied recently, and people are trying to look at it and sort of provide the treatment, especially the surgical treatment for this age group, which was taboo before, and people were sort of trying to avoid it in that age group. Depressive disorder or major depressive disorders among female is another issue that has to be sort of thought of. Now we come to the issue of cancer. And there is, of course, no hard data, but there is a lot of leading points in cancer of the colon, breast cancer, endometrial cancers, and all the biliary tract cancers. Osteoarthritis is another major problem. Now, sleep apnea syndrome is a major disease that people are ignoring or are not sort of aware of. Now, just to elaborate on this a little bit, sleep apnea syndrome means that somebody is unable to go into the deep mode of sleep, which means that they stay on the shallow sleep. Now, we have to know that for somebody to get a good rest, needing at least 4 to 5 hours of deep sleep. And of course, those who has especially the central obesity are unable to go into the deep sleep, because if they do, immediately they will go into sort of brain anoxia, and they probably won't even wake up. Therefore, they keep swinging between the deep sleep and the shallow sleep, and that will make them wake up with a feeling that they haven't even slept, although they've done like 8 hours sleep. Now, menstrual problems, infertility in women, and other issues that is, of course, considered as a complication of this obesity. Excuse me, how can we take these pictures away from here? Because part of the talk I cannot see. Can you just put it on the top or something? Yes, thank you. All right, now obesity in childbearing age. I actually thought of putting it in this phrase. And as you could see, it can cause serious pregnancy-related medical complications. So as you are all aware of, hypertension in pregnancy, diabetes, gestational diabetes, and it has been, there is a lot of data saying that it can cause prematurity and increase the likelihood of cesarean birth. It also reduced the fertility and increased time taken to conceive. And I can tell you a lot of examples of patients that came to me with years of inability to conceive, and you know, within like a few months from doing the surgery and losing weight, they come with a big smile, happy that they've sort of got pregnant. And of course, that is a major part of happiness for those people. Now, women with obesity can also experience difficulty during labor and the delivery. Of course, you all know that they've got big babies, and I just heard from the last lecture about a baby which is more than 5 kilos delivered in a normal way. I feel sorry for the lady delivering that baby, because I'm sure she will need a lot of plastic surgery after that. Now, obese pregnant women are more likely to have early pregnancy loss. This has been studied and found recently. other problems like congenital fetal malformations, delivery of a large for gestational age infants is a major issue, which is ending into a higher number of cesarean sections, as you all aware of. Now, I don't know what is the principle here of shoulder dystocia. Probably it's a mistake in the handwriting, but I could believe that probably those babies, when they are trying to deliver them, when they are big and they're trying to deliver them by spontaneous delivery, probably they cause some distortion of their shoulders. Now, spontaneous and medically indicated premature birth and stillbirth are also increased by the presence of obesity. Obesity also during pregnancy. I'm sorry, guys, I just have a bad flu today. Obesity during pregnancy also affect the coming child. It increases the risk of lifelong health problems in children. I could tell you a lot of issues. Part of it actually is the psychological depression on those children, especially when they are unable to join their comrades and play with them and have the fun that the children are. Now, type 2 diabetes and heart disease is blamed actually also for the obesity. Now, when we come to the principle of treatment, as you are aware that everything starts by medical treatment, and of course, me being as a surgeon, I would start or try to put this medical treatment in the corner and sort of try to show it in the dark corner. But I could tell you statistics that comes from the American College of Surgeons saying that both the exercise and the diet together for a year, the yield out of that is only 5% success, which is probably a very devastating result from this. Now, with the emerging or with the upcoming sort of drugs that has been used recently, I don't know how good is the result out of that, but you must have heard about all these Ozempic and all these injections that has been used frequently these days with some good results that could play a role in the group of those patients that could be helpful. Now, saying enough of the non-surgical, let's go to our field, which is the surgical sort of treatment of obesity. Here we're talking about two major groups, the restrictive and the malabsorptive. Now, what I mean by restrictive is by reducing the capacity of the person to take food, which means that we are reducing the size of the stomach by 100 different ways. But a few of those commonly practiced or used ways is, of course, the gastric sleeve surgery. We've been doing this vertical banded gastroplasty years for hair, and we stopped doing that because of a lot of problems with the mesh migration and penetration and all this. So this now becoming relatively an obsolete type of surgery. I still remember how was this adjustable gastric band popular at the last decade, where thousands and thousands of cases has been doing, where we implant a balloon under the skin and we inject and deflate to help the patients to control the intake and induce the vomiting on those patients, with, of course, a lot of problems at that time, mainly, again, the migration and penetration of this band through the gastric mucosa and having problems with it. Now, recently we've been talking about the capsule and the balloon, and those are two method that has been used and has been advocated recently. I would sort of say that they are useful methods to be used. The only problem is the stomach is considered as a muscle, and if you put something inside and you let the muscle contract against this object inside, it means that the muscle will grow bigger. And that is exactly the situation with these capsule and balloon, that after they are taken out, like the capsule is around 4 months and the balloon is around 6 months, we have what we call the rebound phenomena, which means that the patient will feel much more hunger and ability to eat. And that will cause a big rebound or big robust in his weight or her weight. And that is the majority of patients are complaining of this. But nevertheless, we have to say that it is an available method that if the patient use it wisely and efficiently, it could help to reduce weight. Now, gastropexy has come up in so many occasions, and by gastropexy we mean that we are suturing the stomach either from outside or from inside, and keeping the wall of the stomach within the body. I personally do not feel that this is a surgery I would like to do, but I'm sure a lot of my colleagues would do it, and they would claim that it is quite helpful. Some of the problems with it is the bleeding from the area where we suture the stomach, or probably creating pockets of old staying food, and that is probably an issue. Now, I don't know where do we stand with this Botox. I have to ask my colleagues from the plastic surgery. But what I do understand is that an amount of Botox is injected into the wall of the stomach to paralyze that wall and make it less mobile, which means that the food will stay in the stomach for a longer period, and the feeling of satiety will be the major source of reducing the intake. I honestly don't have much information about this, and I wouldn't be able to report to you how good it is. Now let's move to the other sort of principle, which I personally like and I have advocated since 2001 by doing so many classical and mini and other gastric bypass surgery. Now, what I mean by malabsorptive is that I take two principles to control the ability of the person to lose weight. One is by reducing the amount of the food, which is at the best 30%, and 70% of the method is depending on reduce the absorption of the nutrients from the small bowel. Now, the example is a lot from these surgeries, and it has jumped from different procedures over years and years. Now, I just have to warn you that these procedures are well known since more than 70 years, a cumulative sort of experience. And we've run from ilioileal bypass to biliopancreatic diversion, which is actually a procedure that we love to do for the super obese, which means that the body mass index above 50 and so on. One anastomosis gastric bypass, which is also called the mini gastric bypass. I do a lot of these procedures recently. Single anastomosis duodenal ileal bypass with sleeve gastrectomy. Some people advocate doing this procedure, and I don't know much about the long outcome out of this, because I don't think that we do have enough data to comment on this procedure. Now, the last procedure is the Roux-en-Y gastric bypass, and I have to tell you that this is the golden surgery for obesity, as it is being named by everybody in this field. What I mean by the golden surgery for obesity, it's been practiced all over the world. We have enormous amount of cases, and we know so much about this surgery. The only revolutionary part on this surgery is that we used to do it by open surgery at the mid 70s and 80s, and now we are able to do it since 20 years by laparoscopic. I have started doing this surgery at the beginning of the 2000, and I must have done something like 2,000-3,000 cases from it. And until now, I see a lot of my patients coming to me after 20 years with a weight that is relatively at the best could be achieved. Now, coming back again into the restrictive procedures, I won't stay long here, but as you could see on the left side, the sleeves, the famous sleeve surgery, and my colleague, Dr. Naif, will tell you much about it. The second one is the vertical banded gastroplasty. I have done a huge number of these cases. I've stopped doing it since something like 7-8 years because of the problems that we were facing, but it was not a bad surgery, and we've got a lot of weight loss from that. Adjustable gastric banding, I was never part of this of the team doing this, and I've never been sort of an advocate for this surgery, but there is a lot of data which support this type of surgery, and I'm sure a lot of patients has done it, you know, over the years. Now, these are some of the other restrictive procedures like the capsule, and I'm sure somebody will probably be able to tell you about the capsule. My only concern about the capsule is that people are telling us that this capsule, when it goes down, it inflates and stays for 4 months. Now, I don't know about this fact, that they're sort of claiming that it goes up to 400 mil. This is a concern for me because the stomach is more than 600 mils, and for you to be able to constrain or to stop the stomach from functioning and in sort of requesting the food is to have a bigger volume than this. But I'm sure the people who are doing it in a regular way could tell us more about it and elaborate to us about it. Now, the balloon, I still believe that it's an excellent procedure, and it is, believe me, a good procedure for those patients who comes to you with a body mass index in the 60s and 70s. Those patients are quite difficult to sit on the table and to be able to perform the surgery because there is no much air you can push inside the abdomen to keep the abdominal wall away from the organs and be able to do the surgeries. So for me, for the super obesity, those above 60 and 70 body mass index, I think the balloon is probably an excellent bridging surgery or bridging tool, which we can use to perform the surgery later on, as I mean the other types of surgery. Now, the gastropexy, I leave it to the experts to tell you about it. I haven't done it, and I don't have much about it, experience about it. Now, the malabsorptive surgeries, as I have been talking about, there is different versions of these surgeries, and the major principle of this is that we have to exclude part of the absorption of the small bowel. Now, is that going to be 30% or 40% or more? It is a big issue because if we go beyond 90% or let's say 85%, we have the risk of developing malabsorption syndrome. And I have seen, as a transplant surgeon, I have seen some of those patients ending up in needing a liver transplant. So we have reformulated our surgery, and now the principle is we don't go beyond 30% exclusion. And for that, we tend to measure our total bowel length and go for the 30% out of that length. So, for example, in the classical gastric bypass, we go for 150 centimeter of the by alimentary limb. And for the mini gastric bypass, we use a 200 centimeter length loop. Here we are for the classical gastric bypass, Rho and Y. And as I have been telling you, just a simple explanation, as you could see up, the pouch on the top, which is around 60 millimeter sort of pouch, which is relatively a good restrictive effect. And then as you could see, the food will go down into the alimentary limb without being digested, and then it will meet the biliopancreatic limb on the other side, and then start the absorption when the food join the secretion from the gastric and pancreatic area. So what we are doing is making like a detour and separating the food from the secretion and ending up by causing relative malabsorption. What we have in this surgery is that it's a fully reversible surgery, and that is one of the positive things about it. Now, the cons and pros, we've have sort of explain it while I'm talking about. For the gastric sleeve, it resets the point for the patient, and it will help the patient to change his and her habits, which is a good thing. Hunger hormone is reduced dramatically, and that is a very good effect from the sleeve surgery. It reduced the food intake, it increased the feeling of fullness, and it increases the digestion, because we claim as surgeons that the food will stay shorter in this loop, and therefore the digestion is increased. Now, the cons is the complications, which is, of course, by all types of surgery, stapler line defect and bleeding, and I don't know about abscess. I haven't seen an abscess in my life from a sleeve, but it is there. It's a restrictive only procedure, which means that after some years, we are going to face the weight regain problem in this surgery. Nutritional deficiency is very limited, and the vitamin required is very limited as well. The post-op diet, there is a classical diet that has been sort of put forward for everybody. Now, let's talk about the malabsorptive. I'm trying to run quickly with the time. The malabsorptive, the best thing here I could tell you about the malabsorptive is the sustained weight loss with limited dietary compliance, which means that our patients, especially those which are sweet eaters or what we call the binge eaters, those are going to cheat the sleeve surgery and be able to overcome the restrictive element of that procedure. Here we corner them because we depend only on 30% on the restrictive element, and 70% comes from the malabsorption. Now, especially when we talk about the sweet eaters, because those, they can limit their benefit from the restrictive procedure. The rest of the problems, actually one major part of the malabsorptive procedure is the efficiency for those who are diabetics, because just to elaborate on this, diabetics, complications of the diabetes are not treated by the anti-diabetic treatment. We are only trying to cosmetically improve the blood sugar. But by the doing of the malabsorptive procedures and by inducing the dumping syndrome, we are treating the diabetes, which means that we are limiting the complications of the diabetes, i.e. the renal failure, all the ophthalmic problems, and so on and so forth. So malabsorptive procedures, and there is a formula that I have invented myself. Anybody with a body mass index above 45 and age above 45 with 1 or 2 complications like diabetes, hypertension, and you know, I advocate, now this is my sort of way of doing it. I have colleagues that probably will not agree with me on this, but I believe that those patients with those problems, they might benefit from the malabsorptive procedure in the future better, especially when they the statistics are saying that 10 years of weight maintenance after the malabsorptive procedures is up to 85%. This is an extremely good result that could help us to advocate this type of surgery. I will go over this. Yeah, as I just explained, you know, that's the benefit from those two types of surgery. I do apologize for going over my time, but any question I'll be happy to answer.
Thank you very much, Dr. Atif. It is very comprehensive lecture about bariatric surgery. And the question is that if a patient during reproductive age has this bariatric surgery, how many months you give her a chance to try to get pregnant?
Usually, the time is not actually fixed, and you could see a lot of examples, but I have seen patients conceive like in a month or two after doing the surgery. The chance is always there because you are improving their hormones, their periods gets better, you know, their cystic disease of the ovary gets better, and we could show this by doing multiple ultrasounds. So there is a lot of factors that gets better after the bariatric surgery, which will give them a better chance of conceiving after doing the surgery. Now, the period, I can't find anything in the literature which tells exact period, but maybe Dr. Naif, my colleague, has a period or has read something. But from my side, I have seen a variation of 1 to 2 months after the bariatric surgery and many years after the bariatric surgery.
Thank you very much. Thank you. Thank you, Dr. Our next speaker is a well-known, famous, and eminent and international bariatric surgeon, consultant, Dr. Naif Al-Anazi. Dr. Naif Al-Anazi in our hospital SGH Riyadh will give us a talk about bariatric surgery and infertility. Dr. Naif, تفضل.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Lutfi, for this opportunity to talk about the role of bariatric surgery in the management of female fertility. Okay, what to change? هذا. Yeah, I will go through some topics. Maybe Dr. Atif, he went through. I'm gonna just summarize the things that is not elaborated more with Dr. Atif presentation, but I will concentrate more on the other side of bariatric surgery and fertility. So we're gonna go through degrees of obesity and what's the impact of obesity on fertility and reproduction. How strong is the evidence supporting the weight loss, and too many other topics. Most of you knows that obesity is one of the common disease worldwide, and it's one of the serious public health problem in 21st century, and it's leading to a preventable cause of death worldwide. Here is some causes of obesity Dr. Atif went through. In just summary, it's genetics, either behavior or environmental. Some significant comorbidities associated with obesity, if we are going to go through depression, gastroesophageal reflux, cardiovascular diseases, some kind of cancers like breast, uterus, and colon, some gynecological abnormalities like abnormal menses, infertility, and polycystic ovarian syndrome, and stress incontinence, obstructive sleep apneas, diabetes, hypertension. So it's too many diseases that correlated to obesity as a complication of obesity. Most of you knows that the body mass index is one of the markers to elaborate is this person has obesity or no. How we can calculate this one is through the equation that dividing the weight in kilogram over the meter in square. The outcome can lead in which direction patient goes. If the BMI is more than 30, that means patient is going in obesity. Then we're going to classify it more as a class 1, class 2, class 3. As you can see here in this slide, when the BMI is more than 30 but less than 34.9, that's classified as class 1. More than 35 till 39.9 is class 2 obesity, and more than 40 it's an morbidly obese or class 3. There is another way of calculation the obesity, measuring the obesity, is weight-hip ratio, which is correlate more with the metabolic disorder. The prevalence of obesity worldwide in 1997, the WHO formally recognized the obesity as a global disease. A global disease that need to be treated. In 2008, the WHO claimed that 1.5 billion individuals over an age of 20 are considered obese. So the obesity rate is increasing worldwide. There is some data that I will just keep it here just to read, but the most important, what's the impact of obesity on fertility? And there is an association between obesity and reduced fertility primarily as a result of ovulation and anovulation. In one study of 500 women, there was a 30% reduction in the rate of conception with each 0.1 point increase in the waist-hip ratio. There is a comparison with the normal weight woman with the polycystic ovary syndrome. Those obese women with the PCO are characterized by worsening hyperandrogenic state, worsened metabolic state, and poorer menses, poorer ovulatory performance, and poorer pregnancy rates. So the obese women with the PCOs often report extreme difficulties in losing weight. Comparing with a woman with a BMI of 25 or less, women with BMI more than 25 having a lower chance of pregnancy following the IVF, and required a higher dose of gonadotropins, more days of ovarian stimulation, and have an increase of miscarriage rate. What's the effect of obesity on ART? There is insufficient evidence on the effect of BMI on live birth, cycle cancellation, and ovarian hyperstimulation syndrome. Further studies are needed to investigate the true impact of weight on the outcome of ART. As you can see here in this slide, the obesity effect on the following: on the pregnancy itself, that can lead to miscarriage, pulmonary embolism, and gestational diabetes, and the effect of obesity on the labor risk, postpartum risk, and fetal and neonatal complications. All, if we are bringing all together, it's leading to a maternity death if not treating the obesity. So the British Fertility Society guidelines saying that fertility treatment should be demanded in a woman who are morbidly obese until they have lost weight to below a BMI of 35, although in those with more time, a weight reduction to less than 30, BMI 30 is preferable. And the American College of Obstetricians and Gynecologists, they mentioned that the women who are obese increase their chance of getting pregnant and reduce their risk of pregnancy complications by having bariatric surgery. So the outcomes after delivery for both mother and child were acceptable, provided that adequate nutrition and vitamin supplement was maintained. The weight loss in general, there is two ways of going with to lose weight, either to go with a surgical or non-surgical option. If we go with the surgical, we know that bariatric surgery and the details of bariatric surgery I will go through, and the non-surgical, either to go with a first line of treatment of non-surgical option, to go with exercise, dieting, or medication or behavioral changes. The traditional methods of weight loss are less successfully than bariatric surgery to induce successful long-term weight loss. So bariatric surgery, we know that most of the women, regardless if they are going for pregnancy or not, or in general population, bariatric surgery is giving more good result in weight loss comparing to the other modality of treatment. Yes, it is fast and it is giving good results in for a long period of time, but there is some patient that they are not eligible to go through. That's number one. Number two, let's say that if the patient goes in the right way after bariatric surgery to prevent weight regain, he should follow the diet and exercise. Some patients, they consider that if they did the surgery and they will be losing weight throughout their life, which is not acceptable. This thought should be changed, because if you are not, it's a matter of lifestyle modification. If you are not changing your lifestyle after bariatric surgery, you will get obese again in a couple of years. But if you change your lifestyle from dieting and exercising, that you will get a good lifestyle in the future. So you will not be obese one day, and you will not get the medical problems that are related to obesity in the future life. So the target group in bariatric surgery with the current guideline, bariatric surgery is considered the first line treatment in adults with a BMI above that 50, which is all we agreed on that. And if it's considered for patient, if the BMI more than 40, regardless the comorbidities, and the BMI more than 35, there is comorbidities related to obesity like diabetes and hypertension. And there is some recent studies that mention in American Society, the American Society of Endocrinologists, they mentioned that if patient with a diabetes type 2 and his BMI more than 30, they advise to go for bariatric surgery, especially the sleeve gastrectomy, which is giving a lot of excellent result that they support the bariatric surgery procedure to treat the patient with BMI more than 30 with diabetes type 2. So I will go through quickly through the types of bariatric surgery that my colleague Dr. Atif went through as a restrictive procedure, like gastric laparoscopic adjustment gastric band, or sleeve gastrectomy, which is the most common procedure nowadays. Most of the patients, they go for sleeve gastrectomy because we are not changing the physiology of the anatomy of the gastrointestinal system. It's just mattering the decreasing or smalling, cutting the stomach in a smaller size, decreasing the size of the stomach without changing the physiology or the anatomy of the gastrointestinal system. The gastric band, nowadays, no one is doing that for a reason, for many reasons. One of these reasons that the complication rate of gastric band is much more, seeing that nowadays with band erosions, gastric outlet obstruction, bleeding, migration of the gastric band inside the stomach, which is all alarming that this band is not giving a good result comparing to other options of surgeries. The other combined procedure that goes with the restrictive and malabsorptive is the gastric bypass. There is two types of that. There is gastric Roux-en-Y gastric bypass, and the other one is the mini gastric bypass. And the malabsorptive, pure malabsorptive procedure like the biliopancreation. And nowadays, even this kind of operation is very advanced. No one is doing that unless the patient, there is a specific patient that indicated for this kind of procedure. I will not go through the all kind of procedure. I will go with the most common bariatric surgery nowadays is going on sleeve gastrectomy. What we are doing in sleeve gastrectomy, it's like an 3 to 4 small opening in the abdominal wall. We're gonna go with releasing the omentum that attached to the greater curvature of the stomach. After that, we'll use the gastric tube or bougie with the size from 36 to 38 French, cutting the stomach longitudinal, removing this part of the stomach and leaving the around 20, we'll resect 70 to 80% of the stomach, leaving 20 to 30 part of the stomach in place. So by creating a tube-like structure, we're gonna decrease the food intake and decreasing the satiety, because the ghrelin hormone is in the fundus of the stomach, that giving the sense of eating. So when we cut the stomach in 70 to 80%, that means still we have 20 to 30% of the hormone is in place. So it will not disappear all of a sudden, but it will take time to decrease over months and days and months. So what's the estimated weight loss? It's around 70%. The most common complication in sleeve gastrectomy, most of you knows that leak, number one, and bleeding, pulmonary embolism, and DVT. A leak or stable line leak is considered like nowadays is less than 2%, less than 2%, and bleeding less than 1%, and pulmonary embolism and deep vein thrombosis less than 0.5%. All these numbers are comparing to the previous years. It's going down. With, most of you know that the technology of surgical technologies is getting better. The expertise in doing bariatric surgery getting more involved in doing bariatric procedures. And with the stable lines that previously we were using, the 2-line stable, now we are using the tri-stablers, which is the lines that giving a good control for stable line. Gastric bypass. I'm doing gastric bypass as a revision case for anyone who's doing sleeve gastrectomy and failed in losing weight, or someone who has lost a good number of kgs, but he regained weight later. So I keep this one as a revision procedure. Yes, we got a very excellent results from sleeve gastrectomy in treating the diabetes type 2 and hypertension, and I will go through that one in one of the slides. The non-surgical options, as we mentioned before, that gastric balloon and gastric capsule or ellipse gastric capsule. The principle on that, the one who is eligible to go for this kind of procedure, the one who needs only 10 to 15 kg to lose. It doesn't need to go for a surgical procedure. It's very excellent option for someone needs only losing 10 to 15 kg. But the only thing that related to this balloon, he needs to be strict on away from sweet chocolates. He needs to walk 30 minutes every day continuously, and needs to drink good number of 1 to 1.5 liter water every day, and he should take snacks between 2 to 3 hours, so keep his body with a good energy. The gastric balloon it's through endoscopic procedure, go for 6 months, but the gastric capsule is staying for only 4 months, then it will dissolve spontaneously, and there is an indication and contraindication for both of these balloons. The aim of surgery in fertility women or obese, morbidly obese, are to normalize the metabolic and psychosocial development, enhance fertility, improve the outcome of pregnancy, and improve the weight and metabolic development of offspring. Here, as I mentioned, how is the effect of bariatric surgery on the medical diseases? Most of the diseases related to the obesity itself is getting improved after the bariatric surgery. If you can see here, the diabetes resolved in 66%, hypertension up to 66. The urinary stress incontinence, 50% is getting resolved. The fertility of the patient, if the infertility related to the obesity itself, so most of the female, they will get fertile 3 to 4 months after bariatric surgery if the obesity is the primary cause of infertility. That's why we are preventing or instructing the female not to get pregnant in the first year to a year and a half after surgery. There is a couple reasons for that. First of all, the mother, she is not able to take her good nutrition to build her body. Two, we are afraid from the neonatal complications like anomalies, congenital anomalies, and macrosomia. We are afraid from that patient is not losing, or the mother, she will not lose the good amount of kilograms before reaching to the level of pregnancy, and to build herself with the good vitamins and minerals. That's why we are delaying the pregnancy till 1 year to 1 year and a half, providing as well that to avoid the miscarriage that can be happen during the first few months after surgery. So the bariatric surgery improving the pregnancy rate, improve the PCO markers affecting fertility, possible decrease in miscarriage rate, reduce pregnancy-related comorbidity, and improve the fetal complication. So the effect of weight loss through bariatric surgery on fertility and childbirth outcome has not been fully elucidated. The case series suggests improvement in the ability to conceive after bariatric surgery, but the studies which document improvement in fertility after bariatric surgery are hampered by lack of power to determine statistical significance. So the effect of bariatric surgery, the effect of bariatric surgery on PCO, that the bariatric improve the markers of PCO which influence fertility, such as anovulation, hirsutism, hormonal changes, insulin resistance, and sexual activity. So this is the most important message. The bariatric surgery should not be considered as a treatment of infertility. The effect of bariatric surgery on miscarriage rate is difficult to evaluate because of a small number of studies. 2 retrospective studies record change. 1 found no difference in miscarriage rate pre and post operatively, and another one record a reduction 17% compared to 11. So compared with the general population, for the fetal and neonatal outcome, the number of congenital anomalies was not increased, and the number of perinatal death not increased. A trend towards a lower mean birth weight, more SGA, the small for gestational age infants, and decreased macrosomia. So what's the management of pregnancy and labor after bariatric surgery? We need contraception, timing of pregnancy, nutritional deficiency, and drug absorption. When the pregnancy allowed, that's what most of the studies recommend 12 to 24 months after bariatric surgery before conceiving, so that the fetus is not exposed to rapid maternal weight loss environment. Patient can achieve full weight loss goal, and any operative complication should be appeared. The contraception after bariatric surgery increase the risk of oral contraception failure with malabsorption. Non-oral route should be considered. The nutritional status after bariatric surgery, most of the nutrition deficiencies are protein, iron, vitamin B12, folate, and vitamin D, and calcium. All these kind of vitamins and minerals should be addressed and treated accordingly. Yeah, in case patient, she had a gastric band and she got pregnant, the most important step when the first she knows that pregnancy is positive, she needs to get the gastric band, the fluid she needs to be get out from the bed so she will not get vomiting. And, you know, most of the female in the first few months after pregnancy, in the first trimester, she will get a lot of vomiting, nausea. In the presence of gastric band, that will be worsening. That's why we need to aspirate the fluid to release the gastric band fully, and she can continue her pregnancy without any problems. So considerations in the antenatal period: delay in the diagnosis of bariatric-related operative complication, including intestinal obstruction and gastrointestinal hemorrhage. There should be a high index of suspicion for gastrointestinal surgical complication. Exploratory surgery during pregnancy may be required to treat these complications. Maternal death have been reported. So dumping syndrome, the hyperinsulinemia and hypoglycemia due to rapid empty of the stomach into the small bowel. Patient with the dumping syndrome may not tolerate the 75 gram of GTT. The alternative measure to screen for gestational diabetes is on glucose monitoring, and for approximately 1 week during the 24 and 28 weeks of gestation. Medications, we'll just give this a slide. In conclusion, obesity has many deleterious effects for women of reproductive age. Obese women are more likely to incur fertility problem and miscarriage. The maternal and fetal mortality morbidity is significantly elevated for obese women due to complication in pregnancy, labor, and postpartum period. The management of obesity requires a multidisciplinary approach, stepwise program with a realistic time. Related goals are required, starting with the modification of lifestyle, progressing to medication, weight loss medication, and ultimately obesity surgery. Obese women who have weight loss surgery before becoming pregnant have a lower risk of pregnancy-related health problems, and their child are less likely to be born with a complication. Lifelong vitamin supplement is advised. It's advised against falling pregnant during the initial weight loss phase, especially the first year. Pregnancy is better to be delayed for 1 year and 2 after surgery. During pregnancy, adequate nutritional and vitamin supplementation should be maintained. Caution should be exercised when determining eligibility for in vitro fertilization in women who have undergone bariatric surgery. Prevention of childhood obesity is priority. In particular, barrier to physical activity in girls and young women should be addressed. Thank you very much.
Thank you very much, Dr. Naif, for this interesting comprehensive lecture. And just a question we want to ask. 60 years old female patient. She's diabetic, hypertensive, ischemic heart disease, and she's BMI 85. What kind of bariatric surgery you prefer for this patient to help her generally for the medical condition and in general?
Actually, what I recommend nowadays, as I mentioned at the beginning, sleeve gastrectomy, one of the first line, if the patient is planning to go for surgery. So sleeve gastrectomy is the first option, and sleeve gastrectomy actually is giving very nice results in treating the medical problems that she has. Because when we start with the first option as a sleeve, in case if she got weight regain in the future, there is another option to go for another bariatric surgery if she in need to
or she is not losing that much of weight. Thank you again, Dr. Naif, and inshallah see you next conference.
Thank you very much. Thank you.
Our next speaker is our eminent obstetrician and gynecologist consultant, SGH Riyadh, Dr. Natalia. Dr. Natalia will give us talk about cervical incompetence. Thank
you. Today we'll talk about cervical incompetence. Cervical insufficiency or cervical incompetence is defined by American College of Obstetricians and Gynecologists as the inability of the uterine cervix to retain pregnancy in the second trimester in the absence of uterine contractions. Epidemiologic studies suggest an approximate incidence 0.5% in general population and 8% in the women with a history of previous mid-trimester miscarriage. The diagnosis of cervical insufficiency is primarily based on the history of previous mid-trimester loss, which can present with the following: painless cervical dilatation and bulging fetal membranes upon presentation in the second trimester of pregnancy, preterm premature rupture of membranes, rapid delivery of the previable infant, rare or absent uterine contractions. In women without a history of pregnancy loss, the diagnosis of cervical insufficiency based on the combination of the following: clinical presentation, physical examination, and ultrasound findings. Most patients are asymptomatic, but some may present with the following symptoms: pelvic pressure, cramping, back pain, increased vaginal discharge. Although the diagnosis of cervical insufficiency may be based only on a history of mid-trimester pregnancy loss, the following measures may also be helpful. Transvaginal measurement of the cervical length has a strong inverse correlation with the risk of spontaneous preterm birth, particularly in women with a history of preterm delivery. Fetal fibronectin testing studies have demonstrated the utility of fetal fibronectin testing with addition to cervical length assessment, with a significant improvement of the prediction of preterm delivery in women with a positive fetal fibronectin and the cervical length less than 30 millimeters. Sonographic measures of the measurement of the cervical length, ideally by transvaginal ultrasonography, is the useful in the evaluation of the patients. A short cervical length with the typically defined as less than 25 millimeters has been consistently associated with an increased risk of preterm birth, regardless of the risk factors. Cervical effacement appears to begin at the internal os and proceed caudally with the appearance of funnel-shaped opening at the internal os, which result in the progressive shortening of the cervical canal. However, the presence of funneling does not add appreciably to the prediction of the risk of the preterm delivery with the short cervix already. In asymptomatic women with a prior preterm birth, serial transvaginal cervical length screening is typically performed starting at 16 weeks gestation and is repeated every 2 weeks until 26-28 weeks. For women without a history of preterm delivery, American College of Obstetricians and Gynecologists recommend transabdominal cervical length assessment at the time of fetal anomaly scan, 18-20 weeks, 22 weeks, followed by transvaginal measurement if short cervix suspected. Although in 2013, Cochrane review did not find sufficient evidence to recommend routine cervical length screening for all pregnant ladies, American College of Obstetricians and Gynecologists acknowledged that this screening strategy may be considered. Ultrasound surveillance of cervical length advocated in women with high and intermediate risk of depending on the history. Women at high risk include those with a previous preterm birth or a second trimester loss between 16 and 34 weeks gestation, previous preterm pre-labor rupture of membrane, less than 34 weeks, previous use of cerclage, non-uterine variant, intrauterine adhesions, history of tracheolectomy. Women at an intermediate risk, including those who have a history of previous false dilatation cesarean section, significant cervical surgery, for example, large loop excision of transformation zone, more than 1 centimeter, or repeated procedure or cone biopsy. According to 2014 practice bulletin from American College of Obstetricians and Gynecologists concerning the management of cervical insufficiency, cervical cerclage, in which a stitch placed at the cervicovaginal junction may benefit women with a history of cervical insufficiency or painless cervical dilatation in the second trimester on physical examination. Cervical cerclage is a mainstay of surgical treatment for cervical insufficiency and is reasonable for the following situations: history of second trimester pregnancy loss with painless cervical dilatation, prior cerclage, placement for cervical insufficiency, history of spontaneous preterm birth prior to 34 weeks, and short cervical length less than 25 prior to 24 weeks, painless cervical dilatation on physical examination in the second trimester. American College and Royal College of Obstetricians and Gynecologists do not recommend cerclage placement for women with a short cervix who do not have any history of preterm delivery, as it has not been shown to be beneficial in this population. Moreover, cerclage is not recommended for the twin pregnancies with a short cervix, as it has been associated with increased risk of preterm birth. Certain lifestyle approaches, such as activity restriction, bed rest, pelvic rest, have not been shown to be effective and thus should not be used as a treatment of cervical insufficiency. As I said before, surgical treatment of cervical insufficiency has long consisted for cervical cerclage, which is placement of stitch in the attempt to improve the tensile strength of the cervix. A cerclage can be placed from transvaginal or transabdominal approach, with the primary obstetric objective of reinforcing the cervix at the level of the internal os, and thus increasing the functional length of the cervix. Of the most common performance procedures, McDonald cerclage is a purse-string suture that passes through the cervical stroma, whereas Schroeder cerclage requires dissection of the bladder anteriorly in order to place the stitch at the level of the internal os, and then also posteriorly to burrow the knot there and close it by observable sutures. And also there is a transabdominal cerclage, typically reserved for patients with anatomic limitations, like after tracheolectomy, or those with a history of recurrent failure of transvaginal cerclage. It could be done by laparoscopic or laparotomy. By timing, cerclage could be history indicated, performed as a prophylactic measure About progesterone supplementation during such pregnancies, American and Royal College of Obstetricians and Gynecologists recommend that women with a prior spontaneous preterm birth should be offered progesterone supplementation starting from 16 to 24 weeks gestation and continue up to 36 weeks gestation in order to reduce the risk of recurrent preterm birth. Of note, cervical cerclage has not been shown to offer additional benefit for the prevention of recurrent preterm delivery in these ladies. In women without a history of preterm birth, vaginal progesterone has been shown to benefit women with a short cervix, which is defined as the less than 25 millimeter in this population, resulting in significant reduction in spontaneous preterm delivery. In conclusion, I have to say that contemporary lines of evidence indicate that cervical insufficiency is really a distinct and well-defined clinical entity, but only one component of larger and more complex syndrome of spontaneous preterm birth. Effective and evidence-based management will improve patient selection and permit specifically tailored treatment regimes. Thank you.
Thank you very much, Dr. Natalia, for this interesting lecture. One question is, what is the incidence of miscarriage after applying cervical cerclage?
It's decreased. There is no specific data for it, but if it's indicated exactly for cervical insufficiency, it's decreased dramatically for sure. But there is no specific data. I can't say the specific number.
Okay. Then again, what is do you like to add any medications? Hormonal medications or any other medication as post-operative care for this patient?
As I said, American and Royal College of Obstetricians and Gynecologists not advise to addition of any progesterone supplement for these ladies. Usually, cervical cerclage is enough to prevent the premature dilatation of the cervix.
Okay, thank you very much for thank you very much, Dr. Natalia.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
يعطيكم العافية جميعا. Is it my turn, Mr. Tamer, to start?
Yes, our next speaker, Mr. Fawaz Al-Kharabsha. He is our group experience improvement manager, SGH group in Riyadh. He's talking about how to improve guest experience in the hospital. Dr. Fawaz, تفضل, you can start.
Thank you, Doctor. Thank you. Thank you for this opportunity, and it is really helpful to take chance in such scientific seminars in order to spread the culture of the experience function and the importance of the experience. And in order just, to start immediately in this, again, I'm Fawaz Al-Kharabsha. I'm the Group Experience Improvement Manager in Saudi German Health. And today I'm going to take you to a very short journey in how to improve the guest experience in the hospital. Once when the patient, the customer, the guest arrives to the facility, the hospital, or any kind of organization, they look like this, let's say, flower. And with time, we will, let's say, or that patient, that customer, their experience, based on their experience, are they going to keep all the leaves of that flower, or it's going to fall down with each and every interaction that happens, if it is a bad one or if it is a good one. Once they receive a bad interaction in any of their, let's say, journey points, they will become as the last flower. So when we say what is the patient experience, or what we call it nowadays, the guest experience, Walt Disney have a definition for such experience as their guest experience, that I want to have a place that is as clean as anything could ever be, and all the people in it are first-class citizens and treated like guests. So this is Walt Disney point of view in addressing such definition. We have also another key person which is Van France, the founder and professor in Disney universities, that he believed that everybody that works needs some intangible goal. We all want something that is bigger than what we are doing. So the common purpose that, let's say, a great institution in the experience, in creating a good experience, is Disney. And the common purpose that they have planted in each and every one of their staff, that they need to create empathy by providing extraordinary care for people from all ages and everywhere. So let's move from the experience, let's say, concept in general, to the patient experience in specific inside healthcare institutions. It is the sum of all interactions shaped by an organization's culture that influence patient perceptions across the continuum of care. And it is part of the workforce experience, which is the staff experience, and the staff experience is part of the community experience, and finally, part of the human experience overall. So what matters a lot to the patients, to the guests, to the customers, whatever we want to call them, at the end of the day, they are the beneficiary of our services. To deliver, to build, to act, and to be an outstanding experience by providing compassion, empathy, with smiling and caring culture. So when we say the guest experience, as mentioned, is to be, to act, to build, and to deliver this outstanding experience by merging the compassion with empathy and caring culture all over together. So when we say that Disney and Saudi German Health are offering, let's say, a different experience. And one of the main things that is very interesting, when we say what is more difficult to create a good experience in, let's say, a play park like Disney World, or a healthcare organization like Saudi German Health. And the issue here, or let's say the bottleneck here, that in Disney, people, let's say, are coming to have fun, meeting the emotional needs of a family, to have fun together. And this is, let's say, the common attainable goal that they are trying to achieve by assessing the need. And in Saudi German Health, meeting the emotional needs of a family going through fear, pain, and even tragedy together. So these are the fundamental differences in the experience depending on the nature of the institution. So the gestology, what is the gestology? When we say the guest experience, it is the art and science of knowing and understanding your guests. With let's say, putting in mind that to manage what kind of expectations and raise the bar high by what they desire, what they want, what they feel, what they need. This could define the gestology, or how we use the gestology concept into the experience of the patients, their beloved ones as well. So how we can improve the patients or guest satisfaction? In Saudi German Health, we have adopted an approach and a methodology based on a lot of analysis that was conducted, where communication, empathy, compassion was significantly highlighted as the most important thing. So we have created a concept called CARE. CARE as an abbreviation, not as the meaning of care. It's a program, a methodology, a culture, a daily process, a daily practice. So what does it stand for? So the C stands for connect, and how to connect with patients. A for assist, R for respect, and finally E for explaining. So what is empathy and why? Empathy shows, let's say, in the eye contact, in the muscles of the facial expression, the posture, the effect, the tone of voice, hearing the whole patient and our responses, which leads eventually to better communication. And with that, it was, let's say, identified that through better communication, patients feel well explained, feels well respected, feels connected. And that's how we can assist the patients and their families and their beloved ones when they let's say, visit the organization. The person-centered care, which is a new concept that came in place, adopted by an accreditation body based in the United States, which is a global one called Planetary International. And they brought this person-centered care culture, standards, and so on, as what you can see here, some of the initiatives that ensuring the engaging of our patients in decision-making, where a care partner program that came in place, shared medical records, the bedside shift handover, the shared decision-making, of course. And one of let's say, one of the significant things that there was an initiative that has been created, which is called the Guest Preference Passport, where a patient, upon their admission, they will identify all their preferences in terms of the meals that they have, the time of waking up, the time of sleeping, the visitation hours, the visitation needs, and every other thing that is needed in that matter. So we get to the point that to say that the power of the voice of the guest is summarized in every feedback, which really is a gift for us to improve, to learn, to engage in making the solution and the change. Here I come to the end of my presentation today, and as mentioned, together we build an outstanding experience for our guests. Thank you very much.
Mr. Fawaz, thank you for a very interesting lecture, and we hope next meeting, inshallah, to share with us.
Thank you very much.
One question is that what is the role of the doctor to improve the guest experience in the hospital?
That's actually a great question, as the doctor considered as the main care provider in the eyes of our patients. And the role of the doctor relies more in improving the experience, not only in the clinical part, but in the communication aspect, as what you have mentioned before, where they will explain well the treatment plan. They will engage the patient in decision-making of which plan is suitable for them, explaining the alternatives of whatever recommended by that physician and the consequences. Will explanation showing actual care and empathy will reach to an optimum, an outstanding experience provided by the physician themselves.
Thank you very much,
Thank you,
Mr. Fawaz, and you will see you next meeting, inshallah.
inshallah. Thank you very much.
Assalamu alaikum. Our next speaker, Dr. Ahmed Al-Gitani, our eminent and famous nephrology consultant and internal medicine head of the department. He will give us a talk about pregnancy and chronic kidney disease patient. Dr. Ahmed, تفضل.
Which camera is working? This one. Assalamu alaikum wa rahmatullahi wa barakatuh. I am Dr. Ahmed Al-Gitani. I am a nephrology consultant. I have been graduated from Ain Shams University, and I have a medical doctorate degree in internal medicine and subspecialization with the Arab board in nephrology. Today, I am happy to talk to obstetricians and gynecologists about chronic kidney disease. Of course, pregnancy, you can tell me more and more about pregnancy and about many issues that I don't know, maybe. And also today, we will talk about a special entity, about special patients who are chronic kidney disease and who may get pregnant, and how can multidisciplinary team may make a successful story for this female who suffered from chronic kidney disease, and she was told by many doctors that she cannot get pregnant and how much her pregnancy is risky. But with teamwork and the multidisciplinary team between nephrologist and obstetrician, we may pass with this story successfully with no harm on the kidney or the mother or the fetus. So let's talk first about chronic kidney disease. How can we define a patient that he has a chronic kidney disease? Chronic kidney disease is the presence of kidney damage or decreased in kidney function for more or for 3 months or more, irrespective of the cause. Causes of chronic kidney disease may include hypertension, diabetes, which is most common causes for chronic kidney disease. Sometimes it is drug toxicity for those persons or people who are using non-steroidals and over-the-counter medication. Sometimes we have autoimmune disease like lupus, and sometimes we have urinary tract obstruction or infection, genetic diseases, and also kidney transplant may be considered a reason behind chronic kidney disease. Chronic kidney disease is a highly prevalent global disease, but unfortunately it is underdiagnosed, not like dyslipidemia, not like diabetes or heart disease. Chronic kidney disease is underdiagnosed so much, and we can say that the patients we know to have chronic kidney disease is just the top of the iceberg, but the rest of the iceberg is lying underneath water we cannot see. The global prevalence of chronic kidney disease is over 840 million. About 1 billion person may suffer from chronic kidney disease. And the global yearly incidence of chronic kidney disease is about 19 million. We can see here on this map that the percentage of chronic kidney disease differs from a country to a country or from a continent to a continent based on the screening program and the health status of these countries. Despite chronic kidney disease affect many people, as we mentioned before, that there is about 800 million persons suffer from this disease global-wide, it is underdiagnosed. If we can see on the right side of this screen that about 80% of patients who suffer from diabetes are diagnosed, regardless they are controlled or not controlled, but only 20% are undiagnosed. For dyslipidemia, about 30% only undiagnosed. But for chronic kidney disease, regardless of the stage from 1 to 5, about 90% of the patients are undiagnosed, and they may discover this chronic kidney disease only during pregnancy, which we will talk about later in this presentation. As I told you before, chronic kidney disease is highly prevalent, but it has serious implication on healthcare cost and outcome. On the right side, you can see that diabetes and hypertension constitute more than 50% or even 60% of the causes of chronic kidney disease. And glomerulonephritis and the other causes, as I mentioned before, make the other reasons behind chronic kidney disease. How can we stage chronic kidney disease? Stages of chronic kidney disease is very important. Patient with stage 1 is different from patient with stage 5. Patient with stage 5 is different from those who are doing dialysis or on conservative management. You can see here on the left side of the slide, grading or staging of the chronic kidney disease based on the glomerular filtration rate, which we may consider with AB equation or Madrid equation or Cockcroft equation. These are the estimation. Or we can know the GFR with different other different methods by measuring the GFR through urinary collection or isotope scanning. So on the left side, let's look together in the left side of this slide. We can see stage 1 to stage 5. There are 6 stages because stage 3 is A and B. Based on the GFR, stage 1, we may have to see that GFR is about to be normal or even high. This occurs in some patients who have structural kidney disease, like chronic kidney disease secondary to polycystic kidney disease, or early stages of diabetes where there is hyperfiltration, there is proteinuria, but GFR may even increase in the hyperfiltration stage of diabetic nephropathy. On the right side of this slide, you may see with me that kidney damage is related to albuminuria or proteinuria. That's why we make some screening programs here in this hospital, Saudi German Hospital Riyadh, we make a screening program for for all the patients we have for ACR or albumin creatinine ratio in urine. We have 3 stages. Urinary ACR less than 30, from 30 to 300 and more than 300, which is severe proteinuria. If we collect staging based on the GFR and level of proteinuria, we may spot our patient on a heat map that I will show on the next slide. This heat map, if you will see on the left side here, stage is based on the GFR. On the upper side of the table, staging based on the proteinuria. Whenever you have more protein and less GFR, your patient is at risk. And the risk increase and severity increase and risk for progression and severity increase. As you see with these arrows, increasing risk if we will go to the right and if we will go down. And the prognosis worsens with decreasing the estimated GFR and increasing albuminuria. And you may suffer, this patient may suffer from all-cause mortality, cardiovascular mortality, progression to end-stage kidney disease, or even he is more liable to have acute kidney injury. So let's go back to our title today. We are talking about chronic kidney disease in pregnancy, or pregnancy in chronic kidney disease. I give the introduction about chronic kidney disease. Let's go to see what is the relation between pregnancy and chronic kidney disease. What will happen for fertility in chronic kidney disease patients? If a patient we see in our families, in our friends, diabetic, hypertensive, old age, and he has, we are sure that he has chronic kidney disease. Let's go to a female patient, because we're talking about pregnancy, who is middle age, like 30 years old or 35 years old, and suffer from diabetes for a long time. Because of diabetes, she suffered from recurrent urinary tract infection. She may discover at the time of pregnancy that creatinine is like 2 or 3, and she's suffering from chronic kidney disease. How can we manage this? Let's go to this slide to see about fertility in chronic kidney disease. Why fertility is low in chronic kidney disease, and the fertility may decrease with severity of chronic kidney disease based on the GFR and proteinuria, as I showed in the heat map before. These patients may suffer from disturbance in menstruation, fertility, sexual dysfunction. All these are commonly encountered in chronic kidney disease females. And also they have some menstrual cycle disturbance, irregularity, and even menorrhagia due to coagulopathy and thrombocythemia patients suffer from. Dr. Roger Rodby said, show me a method of birth control more effective than end-stage kidney disease. Having uremia itself is a birth control method. But why don't uremic patients get pregnant? Mostly are older age, they are not 20s mostly. They are beyond the childbearing age. There is decreased libido and decreased frequency of intercourse. Sometimes they have problem in ovulation. There is absence of basal body temperature during the luteal phase of the cycle because of hyperprolactinemia. The axis of hypothalamic pituitary function is disturbed because of hyperprolactinemia, and all this makes them do not ovulate, so they will not get pregnant. Let's put this case in our mind, and then we'll discuss what will happen with this case later on. 32 years old female patient with chronic kidney disease secondary to glomerulonephritis, and its type is focal segmental glomerulosclerosis. Her creatinine is 4.2. This creatinine is stable for long, and she has no children. And she wishes to get pregnant. And she's coming to your clinic, to the multidisciplinary team of obstetrician and nephrologist. How can we talk with this patient? We have chronic kidney disease and we have pregnancy. If we will allow her to get pregnant, does pregnancy have an affection on the kidney disease? Does pregnancy may cause her kidney disease to deteriorate rapidly and reach end stage? This is true. But if we will tell her, okay, don't get pregnant, maybe she will have end-stage renal disease sooner or later. Maybe later because we told her don't get pregnant. But at the end, she will get older and she will be end-stage kidney disease, but you told her don't get pregnant and she will end with no child. But if she will have her child and she has a chance to get pregnant, she may develop end-stage renal disease earlier. But she may choose this to feel the feeling of a mother and having this baby. So let's go and we will discuss this case. The patient with chronic kidney disease. The stage may be 3 to 4, severe chronic kidney disease. Some doctors may tell her, please do contraception to protect your kidney from the effect of pregnancy. So again, the question, what is the effect of pregnancy on kidney disease, and what is the effect of kidney disease on pregnancy? Let's see the answer of these questions, then we will come back to this case. It is a real case and it is a case report. I will tell you what happened with it. Effect of pregnancy on kidney disease. If a patient with chronic kidney disease who will get pregnant, what will be the effect on the history or progression of chronic kidney disease? Degree of proteinuria will increase with about 50% in all cases. Hypertension may develop or worsen in 35% of cases. Severe hypertension may occur, which have detrimental effect on the maternal health, maternal injury, may cause premature delivery and poor fetal outcome because of the effect of chronic kidney disease and the worsening hypertension on the placenta. In mild chronic kidney disease, in the stages of 1 and 2, pregnancy is associated with permanent decline in renal function in only 0 to 10% of women, which is accepted. But in moderate chronic kidney disease, the risk of decline of kidney function is about 40% of cases. The risk of acceleration is highest among those with initial plasma creatinine 2. As I told you, whenever severity is more in a staging of chronic kidney disease, the effect of pregnancy on the chronic kidney disease will be higher. Risk of irreversible loss of GFR may exceed 50% if this patient has uncontrolled hypertension, especially during pregnancy. And also, we found that if patient has creatinine more than 3 or more than 280 millimole, have menstrual abnormality and have much lower chance of conception and even carrying fetus to term. An elevated plasma creatinine above 1.5 and hypertension is the major risk factors for permanent exacerbation of the underlying disease, whatever the underlying disease. And the type of the disease also is important, as accelerated progression have been noticed in special types of glomerulonephritis, especially membranoproliferative glomerulonephritis and focal segmental glomerulosclerosis and reflux nephrosis. The other question, what is the effect of the kidney disease on pregnancy? We know now, and we agree together, that pregnancy will affect the progression and it may worsen the chronic kidney disease and may shift to our patient from a stage to another and may reach to end-stage renal disease. But what is the effect of the kidney disease on pregnancy? What will be the prognosis? What will be the maternal issues and fetal issues? Rate of live birth is above 90% in women with normal or mildly impaired kidney function, as long as the blood pressure is well controlled. Pregnant women with pre-existing renal impairment were significantly more likely to develop gestational hypertension, preeclampsia, eclampsia, and with subsequent complication. Preeclampsia may be more difficult to diagnose in chronic kidney disease. Why? We depend on worsening of hypertension or newly developed hypertension and proteinuria in a pregnant lady to diagnose preeclampsia. But those patients already have hypertension and proteinuria, so it is difficult to diagnose. And even when you diagnose the preeclamptic syndrome in these patients, you will find more difficulty in controlling it, and especially if they have impaired liver function and decreased platelet count. Those patients with chronic kidney disease may suffer from what's called second trimesteric preeclampsia and with subsequent problems. The fetal outcome, frequency of premature births was significantly higher in women with renal impairment, 13% versus 6% in patients with normal kidney function, while non-significant higher rates were noted for IUGR and small for gestational age, 14 versus 8. There were lower fetal survival if blood pressure was not controlled, and 10-fold increase if the mean arterial pressure was more than 105 at conception. If a patient on dialysis gets pregnant, what will happen? Conception in dialysis patient is very, very low. For me, I only see 2 patients who have pregnancy in dialysis, and one of them got delivered to a full-term baby, and the other one have stillbirth. 0.3 to 1.5 of women of a childbearing age may get pregnancy while they are in dialysis. Live births occur in 40 to 50% only. Prematurity is the rule, and average age of delivery is about 30 weeks. There are increased risk of severe hypertension, and similar outcome occur in patients with end-stage renal disease, whether they are doing hemodialysis or peritoneal dialysis. If this patient may have pregnancy, we have to change the protocol of dialysis. In hemodialysis, we may do 5 to 7 times dialysis per week. The usual protocol is 3 times. We may increase it to 5 to 7 times to keep the BUN below 45 milligram per deciliter. More frequent and lower volume of exchanges in patient on peritoneal dialysis. And for sure, we have to avoid hypotensive attacks that may occur during hemodialysis. Let's go again to the case we discussed earlier before we discussed the effect of kidney disease on the pregnancy or pregnancy on the chronic kidney disease. Again, she's a 32 years old female with chronic kidney disease, secondary to focal segmental glomerulosclerosis, and her creatinine is 4. She wished to have a baby. What you will tell her? For me, I will tell her, let's do it together, but you have to know that there will be acceleration in deterioration of your kidney function, but it is her right to have a baby. This patient already got pregnant, but in the 10th week of pregnancy, she complained of progressive oliguria. Her serum creatinine jumped from 4 to 7, BUN 75, and hemoglobin is 7. And for sure, I don't have to explain that this uremic effect on kidney function and on hemoglobin is not favorable for the baby to develop or to have a favorable outcome of this pregnancy. We have the side effect already of pregnancy, and she is in another stage and she may have dialysis. So let's work on the baby to have the good outcome from the other side. We explained to her that we need to do dialysis 5 to 7 times, but she refused, and we did dialysis, extended dialysis sessions, 3 times per week, 7 hours each, because of her refusal to do daily dialysis, and we achieved KT over V between 3 to 3.7. BUN level was well controlled. Protein catabolic rate was average and accepted. Calcium, phosphorus, hemoglobin was okay. When her need for iron and erythropoietin increased. Also, she received the calcium. Pre-dialysis, BUN was 15. I remind you that the target was 45, and the blood pressure was well controlled. Alhamdulillah, she delivered a boy weighing 2.3 kilograms, delivered by vaginal delivery in the 30th week of gestation with uneventful neonatal period. Her kidney function, unfortunately, didn't improve following delivery, and she was maintained on regular dialysis. Again, did we harm her by allowing her to get pregnant? I believe no, because if she may get dialysis after 5 years, she was put on dialysis after 1 year of having this pregnancy. But if you will tell her what you will choose, she will choose to have a baby. Let's talk about pregnancy in patient with kidney transplant. Some females may have kidney transplant only to increase the fertility. Fertility returns, 90% success after first trimester, slight increase in spontaneous abortion. Whatever I will say about pregnancy in kidney transplant, it is for sure, it is not as in normal people, but for sure it is much better than patients with chronic kidney disease or on dialysis. IUGR, premature delivery, occurring up to 20 to 50% of cases respectively. The US and UK registries suggest 14% spontaneous abortion with high prevalence of hypertension and preeclampsia, some developmental delay due prematurity, fewer complication and birth abnormality than dialysis patients, but still not comparable with normal birth. There is increased risk of graft loss if creatinine in the beginning was more than 1.5. Again, I will tell you, whenever you have high creatinine, low GFR, more protein in urine, you will have more severe deterioration of the kidney function. Chronic kidney disease has its effect on the pregnancy, and the pregnancy will have its worsening effect on the kidney function. There is no large or long-term controlled study looking at the GFR and the proteinuria in graft recipients, but I will show you some meta-analysis about this. Birth weight and gestational age seem to be lower in pancreas kidney transplant than in kidney transplant alone. Let's discuss this case together. 30 years old female with end-stage renal disease. She got her kidney transplant from her mother 3 years ago and comes to the clinic. Look at this. 3 years ago, she got a kidney transplant and she's stable on this. This is the most important. She's fully compliant with her regimen, prednisolone 5 mg, tacrolimus, and MMF, and her kidney function has been stable for the last 3 years. She wished to have a baby, and she already have a baby, 8 years old, but she wished to become pregnant again. Will you tell her enough what you have? No, it is her right to become pregnant again. But she has to know that she may suffer and her baby also may suffer. But she will have a more favorable effect than patient with chronic kidney disease before dialysis. KDIGO guidelines, it is since 2009, but it's still the same, that we will not allow kidney transplant patient to get pregnant unless they are stable for at least 1 year. The UK guidelines, NICE guidelines, and the European Renal Association said 2 years. The risk of pregnancy and childbirth for both mother and care are higher. KTRs, which stand for kidney transplant recipients, compared to the general population. But in stable KTRs, pregnancy most often have a good outcome. In KTRs with good kidney function, no protein, with good control of blood pressure, very little risk for graft loss, and favorable outcome for the fetus and mother. However, KTRs with reduced kidney function, we will deal with them as a chronic kidney disease, and they may have the same issues we discussed with the previous case. This meta-analysis show pregnancy outcome of 6,700 pregnancy in about 4,000 kidney transplant recipients, with data spread over different decades from all over the world. Majority of patients preserve their grafts. However, pregnancy after kidney transplant confers significant risk in terms of mother and fetal outcome, including increased preeclampsia, gestational diabetes, cesarean section rates, and pregnancy-induced hypertension. And the risk of prematurity and low birth were also high if we will compare them to the general population. What we will do to a kidney transplant patient who is stable for the last 2 years, we will talk about steroid. It's better to reduce steroid as much as we can. There is association between prednisolone dose and a variety of some birth defects, like premature rupture of membrane, IUGR, with glucocorticoid, and also some patients may suffer from cleft palate with glucocorticoids. For cyclosporine, which is neural, it can induce or worsen hypertension, and the drug levels may fall with pregnancy because of the high metabolism of cyclosporine in blood. So we may measure the level of cyclosporine in blood early in pregnancy to adjust and make increase in the dose. Premature labor and infants that are small for gestational age has been reported. This medicine is excreted in breast milk, so it's better to avoid in breastfeeding mother. And if it is high due to this issue, it's better to make the patient non-lactating. Tacrolimus is better than cyclosporine, but it has the same effects. Sirolimus is completely prohibited. It should be discontinued about 3 months or 12 weeks before conception. And even when the patient is on sirolimus, we have to do double contraception. Recommended to switch to cyclosporine if we are planning to conceive. MMF, mycophenolate mofetil or mycophenolate sodium, it is contraindicated with pregnancy because adverse effects seen in lab animal at lower doses than those used in human. And there is increase in first trimester pregnancy loss, congenital malformation, so it is completely prohibited, and it's better to shift from MMF to azathioprine or Imuran. 2 forms of contraception should be used if we will keep the patient on mycophenolate, and we have to stop it at least 6 weeks before conception. Azathioprine, we have a very good experience with azathioprine. It has less immune suppressive effect than MMF, but we have to use it in a stable patient if they wish to become pregnant. Thank you, and I will be ready for any questions. Thank you.
Thank you very much, Dr. Ahmed, for this comprehensive lecture. One question is that if this patient recently have kidney transplant and she wants to get pregnant, is it allowed to give the contrant ovarian hyperstimulation in form of gonadotropin or other drugs for induction of labor? Second question is that if she got pregnant, what's the maintenance to keep her kidney healthy and the immunosuppressive therapy allowed? Thank you.
As I mentioned, the KDIGO guidelines said we have to keep our patient at least 1 year. And European Renal Association said 2 years. In NICE guidelines, 2 years. So it's better to keep our patient 2 years after kidney transplant to be sure that everything is stable and we minimize the immune suppression as much as we can. Also, control of blood pressure has an effect, level of proteinuria and the baseline creatinine. Patient with kidney transplant recipient who have normal kidney function is different from those with baseline creatinine 2 or 3. Regarding gonadotropin for induction of ovulation, it is allowed with, we have to keep an eye on them because they are more liable for more complication, especially if proteins are higher in urine and creatinine is high. The other thing, induction of labor, and it's better in this patient, although it is not a must, to have cesarean section.
Thank you very much.
Thank you.
Thank you.
Our next speaker is Dr. Mushabbab. And Dr. Mushabbab is a famous and well-known consultant family medicine in SGH Riyadh. His talk will be about the models of antenatal care, systematic review, and meta-analysis. Dr. Mushabbab, welcome to start your lecture.
Assalamu alaikum.
Alaikum assalam wa rahmatullah. Welcome.
Just I need please if Tamer could help me in sharing my talk because it didn't go through with me. I don't know why.
Okay. Sure.
That's good that we have time.
السلام عليكم دكتور مشبر.
أهلا وسهلا بك.
البرزنتيشن مفتوحة على الجهاز بتاع حضرتك مظبوط؟
I know but I didn't go through with it.
هتلاقي سكرين شير موجودة بس دوس عليها.
Yeah, but it didn't connect to my own. Let me see it from other place.
Okay.
didn't unfortunately manage. And because I'm sick these days, and I didn't open it. I didn't already start.
هو حضرتك فاتح البرزنتيشن نفسها صح؟ عشان
Yeah,
لازم
yeah.
تفتح. اوكي. طيب في الزوم دلوقتي مش في سكرين شير موجوده؟
لا ايوه شير سكرين يس.
ايوه وحضرتك هتلاقيها موجوده، دوس عليها دبل كليك بس.
didn't.
مش ظابطه؟
لا ابدا يعني. Let's check some other there.
It was link yes.
Okay خلاص فاتت. Okay done.
اوكي.
I think wait. Okay.
ايوه مظبوط ظهرت عندنا. اوكي حضرتك اعمل
معلش
فول سكرين وابدا على طول. تمام.
سامح لي معلش. Okay.
شكرا جزيلا.
الله يعطيك العافيه. بسم الله الرحمن الرحيم. اوكي اول شيء السلام عليكم. انا مشبب family doctor in Saudi German Hospital. First of all, thank you for all of you for being with me for tonight. Thank you also for having me. Maybe I'm lucky to be at the end to talk because really I got served and I got also knowledge from our expertise that we heard from them. I'm a general practitioner, and part of my job actually it is critical issues and trying to narrowing the gap between the knowledge and the practicality and the implementation of it. I want to share you first one important slide here. I hope this is this one. I'm sorry if I jump in here and there, but because I want to.
بس حضرتك اول سلايد خالص واعمل فول سكرين ليها بعد اذنك.
نعم طال عمرك.
حضرتك بس علم اول سلايد. ايوه دي دوس
أيوة.
عليها بس ودوس بقى فول سكرين عشان تبقى الشاشه كامله.
انا ابغى اروح لسلايد غير هذه اصلا.
اوكي
بس يلا خلاص اتسجل هذا قبل.
تمام.
I want to go to another slide because I okay خلاص. Okay. Okay clear now ها؟ كده كويس؟
كده تمام يا دكتور اتفضل.
Okay. Actually, there is another slide, but maybe I missed the arrangements about it. Tonight, I have followed all the expertise and their talk, and really I got served and I got learned. Seem to be that we have really a lot of knowledge and a lot of experience. But in real, what was in my mind, how to narrow the gap between this knowledge and to put it in the practice. There is other slides, maybe because of I missed it here or there, that is showed the stillbirth and I'm sorry, the maternal mortality rate in America is considered one of the highest in the world, comparing with the very, very rich countries. While the America, they share the economy of about 25% of the overall international economy. And even though this is not reflected in the health services provided, because 80 million or about more, they don't have the insurance not covered or the health services not affordable. So the problem from my view as a general practice, how can we have this knowledge and how can we really in a practice having such things to be applied in simple way? Not a phenomenon of the none, all or none. So the antenatal care, as you know, it is a preventive medicine at the end of the day. We heard from Dr. Shahata that the birth trauma, how to decrease it. From Dr. Atif, the obesity, the problem of obesity, diabetes, and why we have 35% prevalence of obesity in Saudi Arabia. and also from Dr. Al-Anizi, how much this obesity it could affect the fertility actually. In the world, if we want to maintain the population, we have to be within 2.1 fertility rate. But this seems to be decreased because of a lot of things, late age of marriage, or they didn't want children. So as me, as general practitioner thinking of money, so what I pick up how to how to provide the antenatal care as a preventive measure in simple way, and to reach people as out of reach, or to deliver it as easy and as health economics rather than nothing. One of the systemic review and meta-analysis of 15 trials involving 22,000 and more women were included. The pregnant women in alternative care model were less likely, they found, to experience a preterm death. The risk ratio is 0.84 with confidence interval of 95%. The risk ratio with the odds ratio, when we are reaching 1 or less, it means it's actually a good result. And in the subgroup of women randomized to midwife-led continuity model of antenatal care were less likely also to experience preterm birth with odds ratio of 0.78. Overall, low-risk women, and this is mainly actually for low-risk women in alternative care model, where we have to preterm birth is 0.74 odds ratio, a confidence interval, which is good between 0.59 to 0.93. This is actually for the low-risk pregnancy. That doesn't mean that the high risk, they don't need actually to have a shared care. What I'm thinking of, or I believe in, is the shared care always. If pregnant in a pregnancy, thinking also of premarital counseling, not only when just taking care of that lady when she was pregnant, and also pre-pregnancy counseling, and search if she has any other problems that might be associated, other chronic diseases or kidney problems, as Dr. Nasser explained to us. Really, at the numbers that he gave, it was too much. Really, make me so anxious. How even I think we can prevent some of the kidney diseases by controlling diabetes, by also controlling the obesity, by early pregnancy, not after 37, increasing also the prevalence of smoking, a lot of things. So the conclusion of this systematic review of the first one, that would be actually the alternative care of antenatal care of pregnant women are effective in reducing preterm birth compared with routine care. It means with the routine care with the hospital care. Sometimes when you have the tools, when you have the instrument, when you have the OR, when you have the anesthetist, that this might also give also the preterm birth, either by induction, augmentation, or what other modality. The other review, it's the randomized controlled trials. It is comparing the service characterized by continuity of midwifery care. It is systemic review of randomized controlled trials, analyzed an intention to treat basis, in which the study intervention was characterized by midwife or a small group of midwives providing care from early pregnancy to the postnatal period. The 7 trials identified included 9,000 plus women. Main outcome measures were interventions during labor and maternal outcome and the infant outcome. Sorry for this slide, but here we found that the result of the obstetric intervention during labor, like induction, augmentation of labor, electronic fetal monitoring CT, and so on, obstetric analgesia and instrumental vaginal delivery, and episiotomy. However, the cesarean section rate here did not differ statistically in those studies between the trial groups. There was ratio 0.91. So while the antenatal care in men low risk, it's get actually better outcome than those people who might deliver giving birth at the hospital. The lower episiotomy rate in the alternative method of care, it was associated with significant higher rate of perineal tears in the pooled alternative group. It is significant, but when reviewed, actually, the most of those who have the perineal tear, actually, they were young and adolescent pregnant. The proportion of babies with an Apgar score of less than 7 at 5 minutes after the birth was approximately the same in the pooled alternative group as in the control group who went to the hospital. The admission to intensive care or special care baby unit was similar. The difference perinatal death was bordering or statistically significant. The another review was a report of systematic review of other reviews, which examined the impact of having midwives-led maternity care of low-risk women rather than physicians. The conclusion of that, continuity of midwifery care is associated with lower intervention rate than standard maternity care. No statistical significant differences were observed in maternal and infant outcome. However, more research here is really needed because some of the questions have not been answered. A narrative review, systematic review of meta reviews was conducted using transparent and systematic procedure to limit bias at all stages. Systematic review that compared midwife-led care during pregnancy and birth, which physician-led care were eligible for the inclusion. A raising birth rate, increasing complexity of birth, and economic constraint. This is in the American United Kingdom conclusions, because when they want to adapt, actually they adapted during the 90s, some of the home deliveries because of the cost effectiveness to minimize the infection, as you know, because also the health services there, it is free and done by the government. For low-risk women, health and other benefits can result from having their maternity care led by midwives rather than physicians. Moreover, there appear to be no negative effect on mothers and infants receiving midwife-led care. Also, during the 90s, when the British, they want the NHS to introduce such a system of home delivery to convince ladies actually to deliver at home at their own environment and at same safe environment within their family, but for low risk, with actually providing all the facilities that might need if there is an emergency. There is another experience of the Australians to actually the primary maternity care model. And this model, it is outside the hospital in general. It is by the community, within the community, by primary care, midwives, health visitor, and group of care by the general practitioners, by consulting the like diabetologist, the psychiatrist, because psychological illness, that's always actually been missed in the antenatal care. Most of patients, like when we practice and seeing an antenatal care, seeing a pregnant lady, depression is so high, anxiety also is so high. Those mental illnesses, usually it is neglected. That's why the WHO have announced their own guidelines regarding mental health. But as you know, nobody is reading and nobody is following the WHO recommendations. The conclusion of the newer model of antenatal care in Australia may offer benefits over standard practice. It is mainly what I found. The main thing here is also it's for low risk. It is the psychological the impact and to prevent it, and also it's give the psychological support to the mother and within her family and within her community. The WHO is actually for the low risk, they recommend at least 4 visits scheduled and any 8 visit scheduled. The antenatal care options generally include antenatal clinic care in the hospital, midwife, shared antenatal care between general practice and the hospital, midwifery group practice, caseload midwifery, team midwifery, and also outreach, and always the antenatal care in the hospital. Sometimes it could be obstacles or it could face problems like what happened during the COVID-19 outbreak. While at that time we were planned actually to start to have antenatal care within the home care. If you can imagine the ultrasound that it might cost about 15,000 Saudi riyal only, with high resolution, and it might, even if the one who is using the ultrasound, he doesn't know to read why ultrasound, it is a live report. You can consult somebody online, one of the obstetrician, one of the ultrasonographer who might read. But it's not the antenatal care to do ultrasound every visit, or to do the ultrasound of the anomaly ultrasound at 18 weeks, or to detect the pregnancy. The antenatal care, it's more than this. It is it's preventable. It's good, in my opinion, for the efficacy, for the effectiveness, and for the efficiency also. When you talk about the efficacy regarding the availability, maybe the hospital near to you, but it's a private hospital and somebody not covered by the insurance. So even if the facility is there, but he cannot, it's not affordable for him or her. So this means it is not there. In antenatal care, it's not caring of a lady with her baby. It's a caring of a family, caring of her baby, her husband, of all the relatives, the one who is going to come the new guest, with aim to minimize the stillbirth, to minimize the birth trauma, to minimize also the psychological impact, to minimize the postpartum psychosis, to the flu, the depression, and all of this together as a holistic, comprehensive, all-together support. The WHO, when they introduce actually, and they emphasize prenatal or antenatal care, the focused antenatal care, and also the basic component of antenatal care. The focused antenatal care on those who are at high risk, and how even the shared care should be, starting from the countries where we have the general practice, and it's by the governmental issue, then how to focus on them, to detect them early, and ranking those as high risk, low risk, moderate risk, and when to refer to the obstetrician, to the hospital, or to the other specialty, as it's not one-man show. And for the others, just to provide the basic, the antenatal care for low risk. Also, United System has recommended setting up of facility with a capability to provide comprehensive obstetric care, CEA-MOC, for any population of 500,000. and facility with a capability to provide basic emergency in area of 125,000 population. And some countries like Australia, big country, and they have some areas of just 125,000, or even less. They are implemented such recommendation of WHO. What they found, the decrease really of stillbirth, decrease of infant mortality rate, yearly one, and also all the infant, and also decrease the maternal mortality rate. Also, the antenatal care itself, it could be delivered by telemedicine, by phone, by video, by home care, by mobile services, cars, and going to the villages, go to the people. It is here, maybe you think it is a theoretical issue. It is really a theoretical issue, because who is going to provide such service? Who's going to pay? When you compare actually the payment for such services, as always, the preventive measures, it's less than intervention. When you provide mobile services, for example, or home care for those outreach of the remote area, or even near to their home, so you will minimize the defaulters, you will minimize the late booking, so you will minimize the emergency, so you are going to minimize the handicap, you are going to minimize the post-birth, post-delivery of psychiatric, the mental illnesses. This means you are going in the future to minimize actually the cost. At the end, the birth trauma, whatever type of it, then it will prevent, decrease the handicap, because this burden for any government and burden also for any health plan. The core value and component of pregnancy circle, this is the reach for a pregnancy. In NHS, Natural Health Services in England, in the beginning, to start such a program, they actually it's adapted from WHO and between the expert of European and European view of WHO. They want to see how much this, if implemented, how much it's increased the to decrease the burden of birth, the birth trauma, the complications, the stillbirth, the maternal, and all. So when it reduces, it is not one-man show between one doctor and to the pregnant lady. No, it's between all group, health visitors. A visitor, actually, okay, she is the one who is going to visit the lady at home for the first 7 days after delivery. Also, the one who is taking care of a episiotomy, the one who is taking care of a cesarean section, the one who is taking care also of teaching of a breastfeeding before delivery. And also, she has psychiatric illnesses. If she is diabetic, she is hypertensive, if she is in dialysis, as Dr. Nasser said, so you will arrange with her the appointment and all of those issues. I unfortunately missed another slide. Sorry for this. That one of the nice book that published and putting free in the WHO website. It's about 129 pages. It's mainly taking care of mental illnesses of those who are taking care of the mother and the baby, the pregnancy lady, and after giving birth of mental illnesses. This is usually neglected. They want to increase the awareness of doctor to take care of the mental illnesses. What I found from my patient that I am so, because I am general practitioner, I'm seeing variety of patients of different specialties. I have a lot of people with depression, the blue, bad, and they are neglected. They are not in medicine. And people, they are depressed actually before they get pregnant. Why not to give SSRIs? It's very safe in the pregnancy. Actually, even if it's not that much safe, if it's class B, it's better to give instead of this lady depression and the pregnancy. Depression is more dangerous. Pregnancy with depression is really more dangerous. pregnancy, hypertension, diabetes, obesity, and depression, all of those things that come together, they are really big killers. This is what I have to say for tonight. Thank you for having me, and I hope that I made simple, just an idea about how to plan health and narrowing the gap between the scientific knowledge that we have and how we can provide it in efficacy and in effectiveness way, and also with an efficiency. Thank you very much, and excuse me because my common cold that it made me a little bit sub-concentrated.
Thank you very much, Dr. Mushabbab Al-Mufrah. And I hope to get healthy soon and to be in a more comfortable condition as soon as possible from this call. Thank you for this lecture. The question is that, do you think that the midwives in our hospital or in the private sector have a role in the antenatal care or in the delivery room? In MOH, the midwives can conduct delivery. In MOH hospitals, the midwife can conduct delivery. But in the private sector, I think there's no rules.
Wallahi, during my training in the RCOG, the one who trained us of normal delivery, they are midwives.
Yes, this in governmental hospital, but in the private sector.
Even in private sector, because how can we even, you know, if you go back for about 10 years back, now our hospital, Saudi German hospital, we want to move to postgraduate education. So it means that we, inshallah, next year with Dr. Ahmed Nasser Hand and the CMO and CEO, we will have postgraduate. Before the people said no, we wouldn't want doctors, you know, for postgraduate teaching. If you have a standard, you have guidelines, if you have protocols, I don't think that it's risky. Plus, midwives, they know their limit actually, when what to do and what not to do. Let me tell you one thing regarding this. In UK, especially in NHS in England, they're the one who is taking care of the chronic diseases like diabetes, hypertension, asthma, what else? The nurse practitioner, she is a nurse, not a doctor. She is the one who is prescribing. She is the one who is getting medicine escalating and decreasing, and they have also BNF, a nurse practitioner. This is actually, they want to minimize the cost of health. Cost of health, like in NHS, it's costing really a amount of money. So if you have guidelines, you have protocols, you have procedure, everything, I think yes, it could be.
Thank you very much.
Thank you.
Best regards for you.
Thank you very much.
Thank you. Our colleagues, any more questions and any lectures, we are ready to answer. Any more questions? Okay, no more question. Thank you very much, and see you inshallah soon next meeting.
شكرا جزيلا لحضراتكم على الحضور. إن شاء الله بالنسبة للشهادات سوف يتم إرسال لينك تحميل الشهادة، أو بالنسبة للساعات، بالنسبة للناس اللي سددوا الرسوم إن شاء الله سوف يتم إضافتها الأسبوع القادم. لو في أي استفسار تقدروا تتواصلوا معايا على تليفوني 0502 466 292. Thank you so much for your attendance. Regarding the certificate, we will send it to your email, and with the same hours, it will be added by next week. If you need any information, please communicate with me. My mobile number 0502 466 292. إن شاء الله نشوفكم المؤتمر القادم. شكرا جزيلا. السلام عليكم ورحمة الله وبركاته.